Good morning. I want to thank Dr. Shaw and Dr. Vitek for inviting me, and Dr. Woodruff, of course, for organizing this conference. I'm Jeffrey Gross. I am a radiation oncologist. I'm Sloan Kettering, as mentioned. And today I wanted to focus on radiation, give a little bit of background in terms of the issue of gonadotoxic therapies, radiation in particular, and give some background. But really, I want it to be a resource to explain, some of the physics of radiation, and which is something that we maybe learned in pre-med and have since happily forgotten about. So I want to review some of that a little bit and how it's relevant to our patients. So with no further ado. So the basic, this is sort of the general principle of everything, is that, the practice of oncology or radiation oncology or really medicine in general is always sort of this delicate balance where we want, our patients have a problem that we're trying to help them with. And, that which we give them is, has some ability to achieve that goal. But at the same time, if we give too much of it, we can cause problems. So, it's sort of this balance of trying to give just enough radiation in this case that we can cure a patient's tumor or cancer, but, it sort of comes at the cost sometimes of causing late effects. And that's really the delicate balance. And I've heard Dr. Woodruff say in a good way is to summarize this idea is that our mission is to try to help the patients of tomorrow receive better treatments than today and have fewer complications of treatment than today. So it's both, we want cure, but we also want our cake and to eat it too. We want them to have a better quality of life with that cure. And that, becomes very relevant when we talk about fertility. So the goals of this talk is to give a broad overview of, the scope of the problem, how the intersection between radiation biology, the anatomy and physiology of reproduction, and some of the current techniques used in radiation and how these things all interact. And, when you see a patient that might be considering a course of radiation, what are some of the considerations and options that they have to help with their fertility? All right, so, sorry. This slide is just meant to give some broad overview. I mean, there's, the issue of fertility has been studied in a lot of different populations. But predominantly, it's been studied with respect to the child, adolescent, and young adult population in particular, and this is just to give some sense of really, if you look at by decade, from the 60s to the 70s to the 80s to 90s till now, this is looking at lymphoma in particular. But the general idea is that we're doing a lot better in terms of achieving long-term survival. But when you consider the young age of these patients, that survival could potentially result in some pretty significant quality of life issues, especially if there's organ damage or fertility impact on fertility. So more important, or maybe I would argue just as important as looking at survival is sort of what's the quality of life that comes with that survival. So to that we have what's called the Childhood Cancer Survivor Study. This is something you may be familiar with. This is a very large cohort study collecting data from approximately 34,000 patients, pediatric patients and their siblings. And we've learned a lot about not only survival outcomes, but about the long-term health impact of cancer treatments for these patients based on this type of study. Basically this, to summarize to some degree, we see that decade by decade, we've improved our survival outcomes across the board for, pediatric and young adult cancer patients, possibly due to improved treatment techniques, possibly due to better screening for late effects and management of those late effects. So that is a trend that we've noticed. And specifically, when we look at the incidence, so this is looking at the cumulative incidence of grade 3 to 5. So when we, across the board for cancer treatments, we talk about, the grade of side effects. So just to give you some context, grade 3 typically means a pretty significant, a clinically significant side effect. Grade 2 is sort of a more mild or moderate side effect. Grade 4 would be a very severe. Grade 5 is death. So that would be a very severe side effect of treatment. Grade 4 is something that's life-threatening. Grade 3 is something that is serious, but not life-threatening. So this is looking at, pretty significant, in general, side effects from treatment. And we see decade by decade, we've gotten better. And this is looking across all types of cancers, but both patients receiving radiation, chemotherapy, just sort of across the board, just to give some general sense. So we have been getting better looking at the 1970s, 80s to 90s. But when you compare, the incidence of chronic health conditions between the patients themselves and their siblings, you see there's still, a vast, a drastic difference, which certainly we can help to close the gap. So now focusing more on, for our purposes, focusing on gonadal dysfunction. So this study, as we would expect based on everything else we just saw, decade by decade, we have seen improvements in gonadal dysfunction, for cancer survivors. And in this study in particular, they used clinical definitions. This was sort of more of a observational cohort study. They looked at, for males, testicular hypofunction, azoospermia; for females, ovarian failure, premature menopause, and infertility. But the general sense I just want to give is that, decade by decade, even in gonadal dysfunction, we see improvements, probably due to, improved, options for fertility preservation, mitigation strategies, improved treatments. We'll get into a lot of the details in terms of radiation in a few minutes, but things are getting better and better. And as a result, we do see a decreased incidence of severe reproductive complications, but still there's room to do better. So, to understand the impact of radiation, we kind of have to start from the beginning. And now this is an area where you guys could probably teach me a lot more about the reproductive biology, but I just want to focus on a few high points to kind of talk about the intersection between radiation and that anatomy and physiology. So, for males, the primary regulators of fertility or fertility or reproductive potential are both, you need the testosterone and you need sperm, the bottom line. And in order to do that, it all starts with the pituitary gland, as you're familiar with. You have the anterior pituitary hormones, luteinizing hormone and follicular stimulating hormone, that are released in response to the hypothalamic releasing factor GnRH, that then is secreted to the hypophyseal portal system, et cetera, ultimately leading to the stimulation of Leydig cells and Sertoli cells to promote the process of spermatogenesis. So, the point I want to make here is that radiation really could impact, depending on where the radiation is. So something I explain to all my patients is that, when we think of chemotherapy is something that circulates through the whole body and could theoretically, could impact cells pretty much anywhere. Radiation is a lot more, it's more specific in the sense that the side effects really come to where are due to where the radiation is being given. So if we're treating a brain tumor, impact to the pituitary gland is going to be a significant driver in causing, any problem to this process of male reproduction. Or anything in the pelvic area where the testes might see some radiation exposure. So that's where the radiation could impact male reproductive function. And this gives some idea. So focusing on the testes for a moment, it's important to recognize that there's really two factors at play. So first, just to explain, when we speak about radiation dose, so the unit of measurement is gray. You maybe have also heard the term rads or centigray. So 100 rads or 100 centigray is 1 gray. So you may hear some of those terms, but basically we speak about fractionated radiation. And what that means is, we need to give a certain dose to, for example, to cure a, Ewing sarcoma, for example, or, pick any tumor. There's a certain dose of radiation, say 55.8 gray or 5,580 rads or 5,580 centigrade that needs to be given. That's the dose that we need to give in some total to effectively cure that tumor. we can't give all that dose at once. It's too toxic to just give one whopping dose of radiation. So we have to break it down into fractions, and typically, conventionally, fractions are given at 1.8 gray or 180 centigrade per day, Monday through Friday over 6 weeks, or whatever the length of time needed to give the total dose of radiation that's needed. So that's kind of what's meant by fractionated radiation. But relative to the sperm or male reproductive function, there's really two factors. There's the total dose that you're giving, but also the fraction size. So how much radiation is being given consecutively day after day, before you reach that total fraction, how does that causing damage? So to explain a little bit better, so if you give a very large fraction of radiation, whether you give it all at once or you give it, in bite-sized pieces, when you get to total doses of around 4 gray, there can be permanent aspermia. So the sperm the testes, are extremely radiosensitive. But even when you're giving much smaller doses, so say we don't reach that total dose of 4 gray, but we're maybe giving 1 or 2 gray in total to the testes, and we're giving it in so that's where the fraction size matters, and that as long as we're below that threshold of total radiation to cause permanent aspermia, if we give a smaller fraction size, we cause a shorter temporary aspermia. Whereas if you give a larger fraction size, the aspermia can last, the recovery can take longer. And this is also showing, again, around 4,000 centigrade or 4 gray. That's where, again, varying studies have shown different numbers, but to approximate, that's sort of around where people agree we're going to see not only permanent aspermia, but also abnormal testosterone due to impact on the testes. Okay, moving now to females. So the story here is a little bit different. So, as I'm sure you're all very, very familiar with, women have are born with a pool of non-renewable primordial follicles, and that pool degenerates during childhood throughout the course of a person's lifetime, until there are, relatively speaking, fewer primordial follicles present at menopause, at menarche, and then that follows decline until you get to menopause, where essentially the ovary is devoid of primordial follicles, to simply put it. And in essence, those primordial follicles are extremely radiosensitive. So, in essence, radiation damage, can decrease the pool of ovarian primordial follicles in addition to other things we'll talk about. So this is just, the point I wanted to make in this slide is to mention that, we speak about the primordial follicles as being important for the pool, the reproductive pool, but really it's also, you need everything for reproductive function. You need hormone productions, architecture, microenvironment, and, cytotoxic therapies, radiation chemotherapy can really disrupt any of these and cause an impact on fertility. So it's sort of, we understand a lot about the primordial follicles, especially at low doses. These are what tend to be affected, but at higher radiation doses, that's when we start to affect the hormone production and the architecture of the ovaries. So here now we're getting a little bit more into the physics of it. So X-rays or photons, in essence, have the physical property of attenuating through tissue. In other words, if you look at the relative dose and the depth in the tissue, as the beam is entering the body, think of attenuation as like the interactions of the radiation with the body. So like those interactions, it's interacting more until you're a few centimeters in depth. There's the most interaction, and then that amount of interaction decreases as the beam passes through the patient. But X-rays, as I'm sure you're all familiar with, kind of pass through and through. There's no stopping. The beam, decreases in its interaction with the body as it goes through, but it never stops. There's so essentially, if you had an ovary that was, say, in the middle of the body, that ovary, if it's in the line of the beam, would be exposed to the radiation. There's no avoiding that exit dose through the ovary if it's in the line of the beam. So they've looked at, so ovarian primordial follicles, as we mentioned, are extremely sensitive to radiation. If you give a very high dose of radiation, you're disrupting hormone production, the architecture of the ovary, all of these functions. So at a very high incidence, you can cause ovarian failure by giving a very high dose of radiation, say 50 or more, 50 gray certainly or higher can cause that. But even very low doses of radiation can cause ovarian failure, not necessarily immediately afterwards, but can cause premature menopause. And that's been studied a lot by the group in the UK, Dr. Wallace. And the principle is that, say you have a patient with a certain ovarian pool of primordial follicles and you give a low dose of radiation, you will, deplete some of those primordial follicles. So now the pool is lower. I mean, this might be an extreme example, but the idea is that if you've depleted that pool of follicles, then following the normal decay with aging, that patient will deplete that pool much sooner than if they hadn't had that damage to the ovarian follicle pool. Okay, so now, continuing to move forward. Next, we want to talk a little bit about some of the historical, background, or what types of advances in radiation treatment have happened over the last 50 years to get us to where we are today. So this is, very early. Well, I mean, radiation has been around for about, over 100 years, but in this context, as it's been studied related to fertility, it really all started with lymphoma or Hodgkin lymphoma, when they used to give these types of what this is called 2D radiation. Basically, if you have, this was in an era in the 1970s and 80s, really before there was CT scans, and basically you have these plain film X-rays, and you're, really hard to see exactly where the anatomy is. But in essence, we're creating. I mean, this is for lymphoma. They're trying to treat the lymph node chains in the periaortic region and in the pelvic lymph node regions. But as you can kind of, again, I added in this picture, but in essence, you can see how the ovaries would very likely get full dose radiation from a simple treatment that is basically just projecting the radiation, straight on into the body, using some shielding to block the kidneys so they're not getting the radiation. But it's very hard to see where the ovaries are when you're giving radiation in this way, and B, even if you knew where the ovary was, because the radiation is being given in a very simple way, it's hard to really protect the ovaries. So this is what was done, many decades ago. But in this context, a lot of reproductive toxicity was observed, due to the fact that the radiation was given in this sort of simple way, which is the best they had at that time. And it's really in this context that the idea of oophoropexy or ovarian transposition was developed. So the principle there is, if the ovary, say, is here, and you know that you need to give radiation in this type of field, if you move the ovary outside of that area, then in principle, maybe you could spare the ovary from that radiation exposure and preserve fertility. So this is something that we still do from time to time nowadays. I get the impression that it happens less and less. It's probably institution specific, but especially because of what's available nowadays in terms of cryopreservation and other means, we don't always need to go to this type of invasive approach to spare fertility. But this is something that's still out there. It has some problems. There can be, ovarian torsion and cysts. I mean, it is a surgical procedure. It may not be 100% effective because the ovary still could see some radiation, especially when certain techniques are used. But it is something that's out there. A potential mitigation strategy for women. For men, because the testes are external to the body, we can shield the testes. So this is something called a clamshell. Basically, during the radiation treatment, if the testes are nearby to where the radiation beams are going to be delivered, this is basically made out of lead, and the testes go inside, and it can help to shield the testes and decrease the amount of radiation, from a very high number to, this is still, from that previous slide I showed you, an amount of radiation that may cause some temporary oligospermia, but we would expect recovery afterwards. So it can at least spare permanent reproductive failure due to the testes being irradiated. Okay, now here it gets really interesting. So over time, so when I spoke about the Hodgkin lymphoma treatment, that was really this 2-beam, it's called 2D radiation type of treatment, where one beam is given from the anterior aspect of the patient's body. The other beam is given posteriorly. And in essence, we get this sort of dose distribution. So if we're looking at a pelvic tumor, this is what you would get. There's no radiation really going over here to the sides, but within that area where the radiation is being given, there's limited ability to shape the radiation or prevent things from getting full dose of radiation. So with the advent of CT scanning and more sophisticated radiation planning techniques, the ability to use more radiation beams to start to shape the radiation became more available. But in essence, now if you have 4 beams coming in, one from this side, one from this side, one anterior, one posterior, you can start to shape the radiation inside the pelvis a little bit better. But now you're exposing more normal tissues to lower doses of radiation because you're bringing in more beams from different parts of the body. And sort of an extreme example of that is, even more recently, we speak about, you maybe have heard of IMRT, or intensity modulated radiation. There, what's happening is you're introducing even more beams of radiation. So now this is with 6 beams. So, we're able to better shape the radiation. We can start to carve out some of the bladder, carve out some of the rectum when we're treating this pelvic tumor. But as a result, there's even more low dose exposure because more beams are entering the body. And I don't have a picture of it here, but sort of the most extreme example of that is something called VMAT, or volumetric modulated arc therapy. Basically, that's where there's the machine, instead of giving 6 discrete beams or 9 discrete beams of radiation, the machine will rotate 360 degrees around the patient, continuously delivering a beam of radiation. And that gets shaped and modulated getting a page here. Okay, sorry. Okay, so that's the principle there. Now, you've probably heard about protons. So let's talk about protons. And really, protons fit into the discussion of, there's a lot of different particles or types of radiation that could be used. So we've been speaking this whole time up until now about X-rays. So there's, again, I don't want to get too much into the weeds, but there's, X-rays, there's different energy of X-rays that can be used. So, but really what we've been talking about up until now is MEV, or high energy X-rays. So when I say quality of dose distribution, that means the ability to shape the radiation and to protect healthy organs that we don't want the radiation to go to. So high energy X-rays have some ability to do that, but protons have more ability to do that. And there's other things that have been thought about. I mean, really, in clinical practice, it's the X-rays and protons which are in use. These other neutrons were used many years ago. They're not used clinically anymore. And these other ions don't exist in the United States. So carbon is something that's in Europe and in Asia, it's used, not in the United States yet, but maybe something in future meetings we'll be talking about. But right now we have protons. So what does it mean that a proton has a better dose distribution? So here's really, if you remember what we said about X-rays, that they attenuate and kind of go through and through tissue, that's because they're chargeless. But protons are basically a charged hydrogen ion. And because it's charged, it interacts with matter differently. So when imagine there's a proton beam that's passing through it, it enters the surface of the patient, and it basically starts to lose some of its energy as it's passing through, until eventually it loses all of its energy and stops. A way of describing that is, this is sort of the depth dose diagram. So if you look again, this is with X-rays, the beam sort of attenuates and passes all the way through the tissue. So if there was an ovary in the line of the beam, it would get irradiated to a lesser degree than what was seen at smaller depths, but still seeing some radiation. And in contrast, a proton beam enters the patient. It's, the proton beam is losing energy until eventually it gets to this, what's called a Bragg peak, which is sort of the maximum depth that the beam, essentially there the beam loses all of its energy and then stops. So if you had something like an ovary, which was just past where that Bragg peak was, or just past where the beam loses its energy, theoretically there should be zero dose going to that tissue like the ovary. And this is just to illustrate that in practice, you can't use one beam. In order to have a clinical proton beam, we have to take lots of these smaller beams to make make it what's called a spread out bragg peak. So, because a tumor is not, this is like 1 millimeter. Tumors are not that small. Tumors are more like, say, 5 millimeters, for example. So we need several bragg peaks to create a beam that's capable of treating a tumor. But in essence, tumors should have a better ability to protect things like the ovaries. So this is now comparing. So this is a patient getting cranial spinal radiation for certain types of brain tumors that's used. And you can kind of see illustrated that if you had an ovary sitting just in front of the lumbosacral spine, with protons, theoretically, the beam should stop and there should be zero dose going to the ovary. So that's where a lot of the interest in using protons, especially when the ovary would otherwise be in the path of the radiation field, that may be helpful for sparing fertility, particularly in women. And then in the last few minutes, I just wanted to quickly, I know we're running short on time. I want to leave some time for questions, but I just wanted to highlight there was some research that had been done under the guidance of Dr. Woodruff when I was in training. And essentially the question we were asking is, so you see here this quality of dose distribution. So as I just illustrated, protons can do a better job of sparing normal tissues, but there's also this issue of the biologic effectiveness. So in other words, we use these terms. RBE stands for relative biologic effectiveness. LET stands for linear energy transfer. This is basically saying, you have the same, what biologic effect does that type of radiation have on the tissues? So, let me show you kind of in this example. So this is basically showing LET, or linear energy transfer, is basically the density of ionizations caused by the particle. So, with things that have, like X-rays have low LET, that means that it's going through the tissue and it's only it's sporadically interacting with matter. So like if there was a strand of DNA in the path of the X-ray beam, it might cause a break in the DNA there, it might not. So it's sort of a sporadic event. But as the LET increases, the ionizations happen more frequently. And you can imagine that if there's a DNA strand, you can find that spot where the LET is sort of just enough that you would always get ionizations happening to get a DNA strand double break, and that would cause more damage than just a single strand break. And then at even higher LETs, there's more ionizations happening more densely. But the RBE is the relative biologic effectiveness that it increases because as the LET goes up, because we're more often causing DNA double strand breaks. But as you go further LET, it's the RBE is relatively less because we're not causing more DNA double strand breaks because it's basically the same. Again, sort of a side point. I don't want to focus too much on that, but the only point I wanted to make is that we did a study to try to if we can prove whether or not protons could preserve fertility. And part of the reason why we wanted to do that is because there are potential concerns about that LET and RBE at the, if you have a proton beam stopping right before where the ovaries may be, could there be some extra impact on fertility? We're not sure. And really, prior to our research, there have been, some studies of the impact of radiation on fertility, looking at primordial follicles, but not using protons. So that was a study that we did using mice to try to, compare the impact of X-ray radiation and proton radiation, looking both at primordial follicle reserve and anti-Mullerian hormones. So, sorry. Basically, I'll just sort of skip to the study conclusions. So basically, we did this study. You can, search, if you search my name, or I can give you, if you guys email me, I can give you the reference to the study. But basically, we did show that from looking at primordial follicle count and AMH, it did seem like the protons were able to spare the ovaries. When we were delivering proton therapy to mice, we looked at their ovaries and we measured their AMH. So, a couple things. AMH is something that should be explored as a marker for ovarian reserve after pelvic radiation. That's something that we showed in the study. The protons were able to spare the primordial follicles. So in theory, that should help with preventing long-term reproductive outcomes. But still, we need agents to block, or this is protons can help with the radiation, but with chemotherapy, we still need agents or strategies to mitigate those effects. So to summarize in sum total, patients interested in fertility preservation that require radiation or chemotherapy, should have discussion with you guys, the appropriate individuals, to talk about their options. When thinking about, each different tumors, there's sometimes situations where X-rays are utilized, sometimes protons are utilized, depending on the clinical situation. But if you're at a center that has proton therapy available, especially for pediatric CNS tumors, sarcomas, lymphomas, these are things that protons are usually covered by insurance for and readily available. But if protons are unavailable, there's mitigation techniques, clamshells for men, transposition for females, or in certain cases, there's the omission of radiation and just using chemotherapy and surgery in some cases, like for rectal cancer, something that's being explored. So here is my email. If anyone wants to send me questions, I'm happy to be a resource to help in any way that I can. And thank you very, very much.
Thank you very much, Dr. Gross. We are very excited to have you kick off the day with us. I think we have a couple minutes. Why don't we, if anybody has any questions, they can post in the chat, and we'll spend a couple minutes on questions before we move on to our next speaker. These are the perils of the virtual world, I always feel. All right, we have a question here.
Yes.
So it looks like the question is wondering about the dosing for the dosing limits for uterine radiation, concerns for uterine radiation. So they're wondering if the 45 greater than 45 or greater than 25 gray dose to uterine radiation is true for proton therapy as well, or if there's different gradations or recommendations for.
Sure. So to kind of go back to, here. So again, I mentioned at the end of the talk some theoretical concerns about LET and RBE, but really in practice, we kind of think about the effectiveness of protons and X-rays as being similar. So like, if we know from previous studies that say 25 or 40 gray of radiation to the uterus is damaging, the same would be true with protons, but the issue is that protons maybe have a better ability to spare the uterus. So again, if we're treating a cervical cancer, for example, it's going to be hard to spare the uterus because that's sort of part of the target. But if we're treating, say, like a sarcoma, a pelvic sarcoma, or something where the uterus is not really part of the target, it just happens to be nearby, in that case, protons would be better in that they could, we could spare the uterus from receiving, that much radiation, or really maybe even any radiation. But it's the same, but in theory, it should be the same dose that causes a problem with X-rays that would cause a dose of protons. It's just that protons have a better ability to spare the normal tissue.
Perfect. Thank you so much, Dr. Gross. We really appreciate your time and taking the time out of your schedule to speak with us this morning.
You're very welcome.
All right.